Good afternoon, everyone. My name is Shannon Kupka. I am the project manager for the Nursing Home Project with Health Insight New Mexico, and I'd like to welcome you to our final half-hour Hot Topics that is taking place in March. So thank you for being here. This webinar is actually brought to you by the New Mexico Department of Health, the New Mexico Healthcare Association, and Health Insight. And it's designed to be a half an hour of great information for people with busy schedules. So hopefully you will enjoy this last session of March. We're very grateful for our presenter. We have Tina Sanchez, who is the MDS OASIS Coordinator with the state for the Operations Bureau, New Mexico Department of Health, Division of Health Improvement. Tina's a registered nurse with 35 years of experience, including 10 years of experience as a health facility surveyor and 5 years as a regional ombudsman in long-term care facilities. She has an administrative background in home health, public health, and quality management. And we are delighted to have Tina here with us today. And so I'm going to turn our webinar over to Tina. Hi there.
Hi, Shannon. Can everybody hear me?
Yes, thank you.
Okay. So we'll get started. Welcome, everyone. As Shannon said, I'm happy to be here today as part of the Dementia Partnership. The partnership itself decided that it would be a good idea to just provide a good basic overview of what psychoactive and psychotropic medications are, and to just give you a whole bunch of information today. It is basic, but it's founded in just regulation, and so as we move through it, I just want you to keep that in mind. I didn't take a lot of creative liberties. I'm taking information from the RAI manual and the State Operations Manual, Appendix PP, and so I'll talk about those a lot as we move through the presentation. The objectives today are here. Upon completion, hopefully you'll have a basic understanding of what the psychoactive medications are in long-term care. Hopefully you'll increase your knowledge of non-pharmacological and pharmacological interventions, and have a basic understanding how to apply the resident assessment instrument guidelines and the regulatory requirements for the minimum data set coding and care planning. As we move through the presentation, one of the things I wanted to ask you to do is to think of a current resident that you either have, that you take care of, or one that you may have had, and think of their quality of life and the impact that you can make, that you could have made in the past or that you can make today moving forward when it comes to medications, because we know they're an integral part of care, and they're administered to achieve various outcomes, diagnose a disease or condition, they arrest or slow disease progression, they reduce or eliminate symptoms or prevent a disease or symptom. Residents taking medications in these medication categories and classes are at risk of side effects that can adversely affect health, safety, and quality of life. So we're going to spend a lot of time on this because these medications are so serious and have such a degree of risk to residents that I want you to always focus on their quality of life. This is why they're regulated. I want to talk about medication management. There's this very specific definition in the regulations, and there's actually several pages in the State Operations Manual and Appendix PP that really give you as a provider what the requirements are and how to meet those requirements. It'll give you guidance as to it'll show you what the surveyors look at when they're in your building, either doing an annual or recertification survey or a complaint survey. So keep in mind, for all of medication management, it's important for the interdisciplinary team to consider non-pharmacological approaches first and foremost, and always along the way. This is the formal definition of medication management, and if you're a nurse, you can see that it's part of the process. It's very similar to the nursing care process that we're all used to. It involves assessment, management, monitoring, and revising interventions, as warranted, as well as documenting medication management steps. So remember, the documentation for all of this is key, and it's crucial in your facilities. An important component is that the attending physician plays a key leadership role in medication management in conjunction with the residents, their representative, other professionals, and direct care staff. All of these folks are considered the IDT, the interdisciplinary team. So keep in mind that resident that I asked you to think about, and if they've been involved in managing their medications to date, or if they weren't in the past, how you can do that with someone in mind for the future. So non-pharmacological interventions. The definition from the RAI manual is approaches that do not involve the use of medication to address a medical condition. So some examples are things like looking at the environment, reducing stimulation such as excessive noise and lighting, extreme hot or cold temperatures, loud conversation, the use of the intercom. I know when I was a surveyor and a regional ombudsman, noise and sound was just something I always tried to pay attention to, because it's where residents would express concerns to me. It would be where I would notice in talking with them that they would get agitated or anxious, and or they didn't even want to have conversation. So keep in mind, those are the kinds of things that on an ongoing basis that really contribute to a resident's comfort level, and can, if the environment is such, it can reduce their anxiety and their agitation. You want to ensure that you provide appropriate assistance with activities of daily living. Things like previous presenters, if this is your first webinar of hot topics that you're attending, we've had previous presenters who have actually spent some really good time and giving quality information about things you can do as well. And this is kind of another visit to that. But reach out to Shannon if you want to have access, if you don't know how to get access to the previous presentations as well, because they've been very good about some non-pharmacological intervention information. Activities of daily living are going to be things like making sure your resident has assistance with eating, addressing their hunger needs, their hydration needs. Can they reach fluids? Are they being offered fluids? Oral care, assistance with washing their hands and their face before meals, when they get up, before bedtime, if that is their preference. These are all things that make people feel better and contribute to their quality of life. And anyone can do this that's taking care of them. Bathroom trips and positioning. Positioning has a lot to do with comfort, and actually for many residents is a contributor to their pain. So you want to be very mindful of these kinds of things, that if you just are watching and listening to your resident, you're going to really pick up on those things. You want to consider, most importantly, a resident's preference. Being a former ombudsman, I'm really big on listening to the resident, asking their permission, asking their for their input. You know, what do they like? What do they not like? So certainly some of them don't want lotion put all over them or a massage. Some of them only like certain kinds of music. Some of them only like certain kinds of activities. But those are the things. Some like reading. Some like getting on a computer. Some need to have a walk, to be out in the sunshine. So those are some examples of things that you would certainly want to also care plan. So it would be exciting and good, and I know a lot of you do that already. I've seen that over the years, but really address what non-pharmacological interventions you're trying to do in a formal way. De-escalation strategies. Chris Burmeister gave a presentation last week on that. If you missed it, reach out to Shannon. And he gave a really good overview on different things. And for me, it's to me all about being proactive. You know, you want to actually avoid escalation so that, you know, you don't have to de-escalate so much, but being proactive. And by being proactive, I think you have to invest a lot of time into your relationships with residents and their families, establishing rapport. When I was an ombudsman, that's the first thing another regional ombudsman taught me. She had a lot of experience, and she said the number one thing to do is establish rapport. You want to build that trust. So if that resident is upset, anxious, agitated, if you've listened to them before, they're going to remember that. You might be more effective with them. They're going to talk to you. And so you'll be more effective in de-escalating them if need be. Now, when residents have difficulty sleeping, nursing home staff should explore, again, the non-pharmacological interventions referred to as sleep hygiene. The definition of sleep hygiene is in the RAI manual, and I included it here in this slide. It's practices, habits, and environmental factors that promote and or improve sleep patterns. So what you'll want to do is individualize sleep and wake times to accommodate their wishes and know what their prior routines are. You have to ask them, are you going to get everybody up at 5 o'clock because it's convenient, or you have staff there? No, you're going to find out and ask residents when they want to get up. And I know that's challenging at times, but that's the way it should be happening. And those are the things. And somebody who goes to bed, not everybody wants to go to bed at 6 p.m. A lot of them are night owls. I was a night owl for my whole life until last year. So I can relate to some of that. And our habits change. Our preferences change. So just because Mr. Smith liked to go to bed at 6 last year doesn't mean now he wants to go to bed at 6. So looking at what promotes sleep for individual people is really crucial. People who are on medications for sleep, this is the kind of stuff you want to have in a care plan. Things you've tried or going to try, things that have worked, not worked, and how you're evaluating that and how it affects the reduction of medication if applicable. So let's talk a little bit about care planning. We know that all these medications, the psychoactive psychotropic medications, increase confusion, sedation, and falls. This is, I think we're all on the same page here. I don't think that anybody would have a problem with that, believing that. For residents already at risk for these conditions, the staff should develop plans of care that address these risks. So you're going to want to really look at, are you looking at mental status changes and accident prevention in your care planning? I know over the years I've seen a lot of that in care plans, but there's times that it gets missed. So make sure that you're doing that. Remember that diagnosis alone may not warrant treatment with medication. So, that's why you're doing so much assessment and monitoring and evaluating and decision-making and discussion, because just a diagnosis alone doesn't warrant treatment with medication. There has to be an underlying cause, current signs and symptoms. You have to know what somebody's preferences and goals are for treatment to initiate it or withdraw it, right? So keep that in mind. Target symptoms and goals for use with these medications should be established for each resident. You're going to be looking at progress towards meeting these goals, and evaluation should be happening on an ongoing basis. One of the things that I always used to pay attention to and would be sometimes surprised with, and sometimes pleasantly and sometimes not so pleasantly, and that's when monitoring sheets were not in alignment with care plans or vice versa. So if your monitoring sheets, behaviors, symptoms, things you're looking for, and your goals are not consistent with a care plan, you have a problem. And that means communication isn't happening between the staff and the team, the IDT team. It could even be from the resident and or their representative. So keep that in mind. Heavy emphasis I want to make on possible adverse effects. These medications should be well understood by nursing staff and really all staff, at least in a basic form. You don't have to be a nurse to be able to know when a resident is different. If there's a change in a resident, that could be your first red flag that you notice. You may be the CNA, you may be the housekeeper, you may be an activity staff person, and you're seeing something different. You want to report that to nursing for sure, so that can be evaluated. Things like any kind of change, and then any, of course, signs of discomfort. I talked about monitoring before, and because one of the main purposes of monitoring is to identify adverse consequences early. This is the formal definition of monitoring that's from the manuals. So we know that we're doing ongoing collection of information, we're analyzing information, such as observations and tests, and we're comparing it to baseline. so that we can determine their response, their individual response to treatment and care, looking at their progress or lack of progress toward a goal. This is the formal definition, too, of adverse consequence. And I'm going to actually read this because this one's crucial. When we're dealing with these medications, it's so important. As I've said, they're serious. They're not without real risk to a person. And again, like I started in the beginning, again, think of the person that I asked you to pull up in your mind. Are there any adverse consequences, do you think, happening with this person? An unpleasant symptom or event that is caused by or associated with a medication, impairment or decline in an individual's physical condition, mental, functional, or physiological status. It may include various types of adverse drug reactions and interactions. So, adverse consequences can range from minimal harm to functional decline to hospitalization to permanent injury and death. So when we think of psychoactive and psychotropic medication that we're going to break down here in a few minutes, we know of a lot of the adverse drug events that can happen with these folks. In Appendix PP, the State Operations Manual, the SOM, there is a link, and Shannon may put it in the chat box today for you. It's a link to the Adverse Drug Event Trigger Tool. It's a tool that's used by the surveyors, but it's a public document, and so it's not a secret. And I wanted you all to have access to it. If you're a veteran and you know where this is in the SOM and you've already pulled this up, wonderful. If you're not, and you're new and you have no idea what I'm talking about, the link will be there. And at the end of my presentation, there's also the link for this tool. This tool is really helpful to you. It provides really the foundation of an investigation for an adverse drug event. And there's a whole category. It's not just psychoactive medication that are in this tool. It's all the meds that are considered high risk, problem prone. And that should be a term familiar to a lot of you who are veterans. If you're new, that's a term you're going to hear quite a bit. So this tool includes what the adverse drug event might be. So for psychotropic or psychoactive medications, it might be altered mental status and delirium. There was a wonderful presentation on delirium a few weeks ago, and I would encourage folks to reach out to Shannon and try to get access to that as well. It gave a bunch of very good information. It was done by a physician. Anyway, back to the adverse drug event trigger tool. It gives risk factors. It gives signs and symptom triggers, so that if the surveyors or you in the facility were using this tool, if you said, oh, you know, my resident is having orthostatic hypotension, you know, that's a trigger. And if a surveyor sees that, that can trigger them to go back and work this backwards to see what medications this resident is on, and are they having an adverse drug event. There's also clinical intervention triggers. In other words, if they see an abrupt stop order for a psychoactive medication, that could be a trigger for them to go back and look. That should be a trigger for you to go back and look. Then there's the last column in this tool is surveyor probes. And these are questions designed to assist them in their investigation. Now, a negative answer for any of these does not necessarily indicate noncompliance, and so that's how you should interpret that as well. But it lists a series of questions and prompts for them to actually do the investigation. There is no reason that you all shouldn't be familiar with this and utilize this. It's not mandatory by CMS, but it's certainly put out there by CMS, okay? Now, when we talk about pharmacological interventions, now we're going to talk about what they are. What are psychoactive and psychotropic medications? This is the definition in the regulations. Any drug that affects brain activities associated with mental processes and behavior. It's a simple definition, but it's really packed with a lot of meaning. So these include, but are not limited to, the categories of antipsychotics, antidepressants, anti-anxiety, and hypnotic medications. So for purposes of our focus today, that's what we're talking about. This is a screenshot of the 3.0 MDS, the minimum data set, section N. And this is the coding that affects your quality measures, some of your facility reports, your facility characteristics. So you want to make sure, and this is why the Dementia Partnership was really wanting to, let's revisit this and go over some of the basics. Because if you're actually coding a medication that's an antidepressant into the antipsychotic area, it's going to mess up your quality measure for antipsychotics. Okay? Same kind of thing. And then in other facility reports, when we get prevalence numbers, they can be off because if you're not coding them correctly. There was a presentation on the antipsychotic measure and coding it about a month ago or so. Jessica Mirabal from Genesis did that, and it was a very strong, really helpful, useful presentation as well. If you weren't a part of that hot topic, you may want to reach out to Shannon on that one as well. I know I'm throwing a lot of stuff at you, but I'm doing that on purpose. So that, because we have a short time, but want to give you a lot of information. And I'm wanting to at least pique your interest into what more is out there. Okay, so when you code these different categories, you're going to indicate the number of days the resident received the following medications by classification, not how it is used. Can't say that enough, not how it is used, and I'll say it some more before the end of this presentation. So it's during the last 7 days or since admission if it's less than 7 days. Enter 0 if the medication was not received by the resident during the last 7 days. So what are antipsychotic medications? I'm using very simple definitions. These definitions are not pulled from regulation per se. I cited the references at the bottom because I do think CMS deliberately avoids defining each one of them. And so I'm, any further or getting very detailed. But to give you a general idea, antipsychotics, of course, treat psychosis such as delusions, hallucinations, paranoia, or confused thoughts. Now, we tend to see more of the second generation, which are called the atypical antipsychotics, things like Abilify, Zyprexa, Risperidol, and Geodon. What are anti-anxiety medications? Of course, these are drugs that work on the central nervous system to treat anxiety. Common drugs that I've seen in nursing homes as well are the benzo, I call them the benzo family, Xanax, Klonopin, Valium, Ativan. I threw in Vistaril there because it is an anti-anxiety medication, but it's used for different things. So, but remember, it would be coded as an anti-anxiety medication if it's been given in the last 7 days of the look-back period. What are hypnotics? Hypnotics are basically defined as drugs that work on the central nervous system to treat insomnia or sleep disorders. And, I, in my experience more recently, have not seen a bunch of these, just a little bit of stuff. So back in the old days, like Shannon said, I'm an old nurse, so I go back a long time, and these were very common back in a lot of my years, but probably some ones that are newer are Lunesta and Ambien. Antidepressants are a broad group of drugs. There's a lot of antidepressants, as you all know, or if you don't know, there are, and they're used to treat depression. They don't cure depression, but they're usually good at improving mood and anxiety, sleep problems, suicidal thoughts. And that's important to kind of look at, because you may have somebody who's being given an antidepressant to also help with their anxiety. Again, you're not going to code that as an anti-anxiety agent if it's an antidepressant, right? Some examples are listed here for you, like Celexa, Zoloft, Elavil. Okay, moving towards MDS assessment. This is taken exactly from the REI manual. I already went through that on the coding piece, so I'm not going to repeat that. But you do want to make sure and review documentation for other healthcare settings that the resident may have been in and where they received this medication, like Valium in the emergency room. If given during the look-back period, you are going to code that. Some other coding instructions, again, you're going to be given it, coding it by the pharmacological classification, not how it's being used. Again, keep in mind, when I was doing this presentation, I thought, well, the body doesn't know why it's being given, but the body is going to know how it's affecting their body. And so that's why we're going to code them by classification, not how it's being used. Medications that have more than one therapeutic category and or classification should be coded in all categories. Again, regardless of how it's being used. Code a medication, even if it was only given once during the look-back period. So this is in the RAI manual. If you're questioning me, I'm going to push you to look in that RAI manual yourself. Count long-acting medications that are given every few weeks or monthly only if it's given during that 7-day look-back period. And that might be drugs like Haldol or Prolixin. Combination medications should be coded in all categories and classifications. If they receive a single tablet that is part antipsychotic and antidepressant, then both of those categories are going to be coded. Over-the-counter sleeping medications are not coded as hypnotics. Let me say that again. Over-the-counter sleeping medications are not coded as hypnotics. They are not categorized as hypnotics. When we talk about reference materials, and I can't probably emphasize this enough, try to avoid looking at drug classifications from drug lists. In other words, you know, here's antidepressants, and they list out all of the drugs. CMS recently, on a call with all of the state RAI coordinators as recently as February, really emphasized this to us, to communicate to providers and to surveyors that they want people, I mean, you can go to the RAI manual and they have a few links, but even their links aren't all-inclusive either, and some of them are drug lists. So you want to, they're recommending more now to consult the medication package insert, which is available through the facility's pharmacy or the manufacturer's website. So especially new staff and nurses, sometimes we think we know automatically, but I think you'll still be surprised, even veterans. And things on drugs are always changing as well. So you want to stay very current. But again, I wanted to emphasize CMS has pushed us all to really make sure you know what these classifications are, that by either referring to a pharmacist or the manufacturer's website. Be very careful. Dosages and duration. I've talked about that a couple of times already. You really want to stay on top of those, using the lowest dose and the shortest duration that's effective, and also referring to current literature on clinical practice guidelines. Clinical practices are not something that if you call me about, I'm probably going to weigh in with you. In my role as a state REI coordinator, yes, I'm an RN with experience, but I'm not going to assist with assessment and or clinical practice. Again, because medications are always changing, you're gonna need to just stay very current. I want to talk quickly about gradual dose reductions. You know, they're required within the first year if somebody's on a psychoactive medication. Also, you want to do gradual dose reductions to avoid withdrawal syndrome, especially for things like the SSRIs and the tricyclic antidepressants. You want to be aware of, and it's not in a slide here, I took it out, but there's a lot of regulatory requirements on PRN dosaging and what's required for psychoactive medications, and specifically too for antipsychotics. So I'm going to refer you to the State Operations Manual, Appendix PP. There's actually several pages on that as a facility will guide you perfectly along the way, what's required, and how surveyors are going to look at those requirements and investigate them. There's a wonderful table actually of PRNs, and you can just print that up. And it should be something, I mean, I would recommend, and I'm not mandating that to you, but I would recommend having those tools like at IDT, those kinds of things, the adverse drug event tool, that can be an IDT, and people should be talking about it. Antidepressants, as we all know, they need to be closely monitored when they're started or dosages are changed, because that's when worsening depression or suicidal ideation behavior can occur. Stopping antidepressants abruptly puts one at higher risk of suicidal ideation and behavior. So really be on top of that as well. Lastly, on the MDS coding tips and special populations from the RAI manual is that I wanted to put this in here. Herbal and alternative medicine products are considered to be dietary supplements by the FDA and are not regulated by the FDA. So these should not be counted as medications per se. It doesn't mean that you shouldn't be keeping track of them and really monitoring their interactions with medications. Examples include melatonin, chamomile, and valerian root. So again, be mindful of that and any possible interactions for your resident. Okay, so these are the references that I've been talking about so much in the presentation. These are the links that will take you to the current RAI manual and the current state operations manual and the adverse drug event trigger tool. This is my information, how to reach me. Please reach out to me if we're a little over our time. So please don't hesitate to reach out to me by email or call me. And if I don't have the answer right off the bat, I will research it for you. I haven't memorized everything in the short time I've been around, so I think you probably can appreciate that. But people who have reached out to me, I think you know that I'll research things for you and get back to you pretty timely. So anyway, lastly, I wanted to say thank you so much for all that you do in caring for the residents who are so vulnerable and who are so deserving of your care. And I know that you do a lot to support their quality of life. So thank you so much. I don't know if there are questions or how much time people want to give to that. Shannon?
Okay. Well, seeing no questions in chat, I'm going to let you all get back to your afternoon. I want to say thank you again on behalf of the New Mexico Healthcare Association, New Mexico Department of Health, Health Insight. We thank you very much for attending today. We will be sending out our next round of half-hour topics and dates very soon, but please go ahead and you're welcome to sign off. If you have any questions, you'll be getting this. I will let you know when the recording and PowerPoint are available on our website. So thank you very much, everybody. I hope you have a wonderful rest of your Friday, and thank you so much, Tina, for presenting for us today. We really appreciate your time.